morning. Morning, ladies and gentlemen. Thanks for being here today. Rising costs, changing demographics, and growing consumer expectations are changing healthcare. Providers and payers are seeking better quality care and improved outcomes, whilst striving for much more efficient models of delivery. These pressures for transformation are changing the status of IT in healthcare as it facilitates an information revolution in healthcare. Increasingly, technology is being used more collaboratively to support and drive substantial cultural and strategic change and provide the infrastructure, processes, and tools to support this. This conference has been developed to provide critical input for stakeholders in healthcare, providing objective, timely evaluation of the different healthcare challenges and applications and solutions for tackling them. Today, amongst others, we will discuss educating the caregivers of tomorrow, where we will look at how new technologies will have the desired impact if caregivers are not given the necessary training. And it's not just about training that is needed. It is an entirely new way of thinking. We will also look at healthcare records in the cloud and its impact in patient privacy and security. And the last panel for today will focus on digital health and IoT. How will sensors and connected devices impact healthcare in the coming years? Without further ado, let's get started. The first presentation is by Dr. Rajeev Eashwari, Director of eHealth at the Department of Health in KZN. Dr. Eashwari, please give him a round of applause.
Good morning, ladies and gentlemen. Hope you had a relaxed evening after a hectic round of presentations yesterday. As introduced by the MC, I'm Dr. Rajeev Eashwari. I'm responsible for eHealth for Department of Health in KZN. This presentation put together most of the time we are bogged down by terms like big data, robotics, and cyber security and others, but we tend to lose track that patient is the most important person we are trying to assist. So creating a value-based healthcare system, eHealth in KZN, overcoming challenges, enhancing access and impact, using ICTs to connect providers, the innovative use of technologies for population health. We are looking at value, health outcomes that matter to the patient, over cost of delivery of the outcome. If you look at the patient satisfaction, patient gets attention immediately, that is what the patient wants. He or she gets attention closer to home, that's again another priority for them. And medication advised is available readily. The reason we have congestion at the district hospitals and the regional hospitals is because we don't have the medication that should be made available to the patient at the clinic level. For the providers, patients get treated at the golden hour, and that gives them satisfaction, and patients are treated at the appropriate level of care. I'll talk a little bit more about that in the next few slides I have. In the good old days, there was no technology, and we had no access to information, no technology, but we still managed. We could sit with the patient, hold the hand, look at the pulse, auscultate, and then come to a diagnosis. Now we see a patient walk in, the first thing we do is take out the X-ray form, fill in the lab test, and wait for the results to come, then only we'll start seeing the patient. So the mindset has to change, but from there to where we are now, we have to use technology because of the limited resources what we have. These are some of the challenges: staff shortages, chronic conditions, aging population, distance between health facilities, paper records, the regulations, the quadruple burden of disease, the medico-legal issues, bandwidth, and of course the cost pressures. That's the paper records. Don't miss, there is a dead bird also there amongst the records, but this is the reality on the ground. We got 80 hospitals, I'm talking about KZN, 80 hospitals on an average. Even if you look at 500 patient folders multiplied by 80, that's the number of folders what we have. The chances of missing them, misplacing them, and patients carrying it away, and folders in wrong hands, we have a lot of problem to sort out. I put this slide together just to highlight what we have. That's the bandwidth, what is available, and this is what is available, about 10% of it. If you look at this, these are the transversal systems, and that takes up 90% of what we have. At a hospital level, all our hospitals are connected in South Africa. They are on the government network, but the bandwidth available is about 2 megabits on an average. 2 megabits, I'm sure, is nothing compared to what you need. But the need is here, where the clinical information, that's the health information systems, where electronic health records and all that come in. And once we have this, then that's where we can look at analytics and social impact and other things that we can look at. I'm sure all of you know about the EMR adoption model. That's where we are on stage 1. We have NHLS that has got a good system. We have limited pharmacy systems, but we are at stage 1. If you look at the telemedicine adoption model, we are here. Using technologies such as video conferencing to support provider. So that's where we are able to do it now. I think we still have to reach at level 7. This was done by, this is a South African study that was done by Ernst & Young. That was in April 2015. The remaining challenges: the need for improved evidence of the economic and social benefits of e-health, problems achieving the interoperable e-health applications. Many pilots for e-health projects exist, but scalability is an issue. Improved collaboration between DOH, academia, and the industry. I think that is most important thing that we need to look at. Yes, it's possible to reduce congestion at our health facilities by avoiding unnecessary and avoidable transfers, by treating patients at the appropriate level of care. Rural health practitioners getting advice in the golden hour so that the patient gets the right treatment at the right time. Using video conferencing for distance learning and for management meetings. That is what we spend on an average per patient when they come into the public sector. As KZN, we are still below the national average, but we still have a problem. This is what we did just for discussion purposes. These are not exact figures, but if you see what it costs for a patient to be seen at a clinic, that's a patient day equivalent. It costs about 200 rands for a patient to be seen at a clinic. The same patient goes to a community health center, it costs about 400 rands. A district hospital about 1,400, regional 1,969, tertiary 2,850. If we talk about academic hospital, it costs about 4,000 plus. So what we did was, just for calculation purposes, we took 100 patients at a clinic, so that's about 20,000 for 100 patients. And then that's what we came up of 269 million. If you look at what we can achieve by just giving support to 10% of the cases that can be stopped at and treated at an appropriate level of care. That means a patient seen at a clinic doesn't have to land up at a community health center or a district hospital. By using technology, we can give them advice in real time. We'll be able to save 26 million just for the 100 patients. That's, like I said, it's only for calculation purposes, but that's a scary thing. Patient lands up at a district hospital just because there is no medication available at a clinic. So make sure that it's available, and it can be done only if you have information in real time. We started talking about telemedicine. It was not moving at all. So that's when we said, okay, let us stop talking about technology. Let us talk about the outreach program. So we have doctors, nurses that go to the lower level and do this outreach once in 2 weeks. So in between those 2 weeks, what we want to do is to use technology. So for a clinic, that's a clinic and that's a district hospital. So the clinic becomes a send site and the district hospital becomes a receive site. So the same thing happens where medical officer gets support from a specialist here. So just by using technology, just by giving them connectivity and reasonable, a robust connectivity and reasonable bandwidth, we can actually achieve all this at different levels. At a clinic level, we can have teleconsultations, we can screen patients for communicable and non-communicable diseases. At the district hospital, one level above, we can have dermatology, radiology, cardiology, psychiatry. We can add teles to any clinical application. And we go higher up, we can have more of those. And once we have the connectivity sorted out, we can look at e-health, telemedicine, m-health, electronic health records, hospital information system, document management, radiology information system, all that is connected. And once we are connected, then we can use the information to manage better. The aim is to reduce the number of patients coming to the clinics or to the district hospitals or the regional hospitals. To create a platform for clinical advice, to connect nurse practitioners to medical officers to specialists, and specialists to super specialists. In today's healthcare environment, we need to have a robust IT infrastructure, and we can use it to improve care, improve the patient experience, and reduce costs. A well thought out mobile development strategy can help us to achieve these goals by putting the right technology in the hands of doctors at the point of care. I don't want to go through the details, but this is what the e-health strategy has defined. So e-health covers electronic health records, routine health information management system, vital registration, consumer health informatics, health knowledge management, m-health, telemedicine, virtual healthcare, and of course, once we have the information, we can use it for research purposes. So we have a national strategy that we can depend on, but we haven't reached there as yet. We're still in the process of doing it. That's the timeline. In 1997, we had 31 sites for telemedicine, and they had the full package, including video conferencing, we had radiology, etc., etc. But it didn't take off because, again, it's change management issues. But we haven't given up on that. We are actually, sorry. Okay, so from then on, so we have the ECT Act that is going to help us. That's the e-health strategy. That's the ML strategy that has been approved. And that's the normative standards frameworks that is going to guide us. And HPCSA still dragging its feet. We still haven't come up to assist us in taking it forward. Yesterday there was a mention of the regulatory authority. Ideally it should have been the HPCSA, but they are dragging their feet. We haven't given up on trying. So in 2013 and 2014 we managed to get 2 national awards in 2 years in the same category, using ICTs to improve service delivery. That's from CPSI, Center for Public Service Innovation, as part of DPSA. That's the e-health strategy. The principles are to get the basics right, take the incremental approach, look for early wins, advocate the benefits, evaluate e-health initiatives, and have national coordination to improve effectiveness of e-health at all levels. That's the normative standards framework that is looking at technical, synaptical, semantic, and organizational interoperability. These are huge words, but once you look at it in detail, it's possible, but you have to do it one step at a time. So it's level 1, local paper-based medical records. You have to do it stepwise. Local paper-based medical records with some IT support. Level 3 should be a shared electronic health record system with mixed mode local medical records. And level 4 would be a fully integrated national EHR system. That's the architecture. The current situation in KZN, because of the limited resources what we have, human and financial, we can do better and make life easier by working smarter, not harder. We have to use technology. There's no other way. We formed a provincial e-health steering committee. That's the committee, and that actually looks at how we can work together and make things happen. We have a representation from UKZN as well on the steering committee. Prof. Mars is here with us today. He is part of the team as well. So once we develop and fine-tune the provincial e-health strategy, that's when we'll include the industry to work together on it. That's on the governance side. That's how we work. That's how we report to national as well. We have at national we have NISA, National Health Information System of South Africa. That's where we report. Progress so far. I don't know if I can talk about this, but it's the only province in South Africa that has got a directorate for e-health. No other province has, unfortunately, as yet. So that's the strategic plan, what we have, the aim and the mission. Uh, there's some of the projects we have embarked on. This is in association with UKZN. Prof. Mas is the one who had actually initiated it about 9 or 10 years back, where we have video conferencing facility in 37 sites, and it's placed in boardroom situation. Unfortunately, it's not helping us for consultations. It can be used only for e-learning for now. But we do have that, and same thing can be used for, same connectivity can be used for telemedicine as well. So those are the sites. We connect about 5 sites at any given point of time. So if there's a lecture from Durban or from Pietermaritzburg, it can be linked to 5 sites at the same time. The teleradiology, we have about 12 hospitals on the teleradiology program, where we digitize images, send them across, and then we get reports in real time. That's another initiative we looked at, to have a virtual hospital concept. We connected 2 hospitals, a urban one where we have specialists and a rural one. So we can actually use it for electives and for emergencies as well. That's the one between Madadeni and Gray's Hospital. Before this, they used to fly to Madadeni Hospital. That's about 220 kilometers away. So they used to fly once in 2 weeks. There's an ICU in Madadeni, but there are only medical officers managing it. So what we have done is we have given them computer on wheels on both sides with digital medical devices that connect, and now they're able to give them advice on a daily basis between 12 and 2. That's what they do. So that means they're doing the rounds every day by specialists based at Grace. So that's the roster we'd like to see happening. This is what is happening now, but as more people join in, more departments join in, then we'll be able to give them connectivity. That's a population health management. We have 2 districts that have implemented the solution. That's for the ward-based outreach teams. When they go from house to house, you give them a digital pen and a cell phone. They collect the information, and it takes about 10 seconds for the information to go onto the web, and that information we can generate reports out of it in real time. We're looking at standardized, the same technology we're going to use in accident and emergency, in dermatology, pediatrics, and burns and psychiatry. That's another initiative we have for chronic disease management, and what we are proposing is to have 1 tele-video consultation room in every hospital. It's a work in progress. We are not able to achieve it, but this is what we're planning. Clinical workstation, that's a computer on wheels I just spoke about. We just have to have a 5-parameter patient monitor, spirometer, a 3-in-1 cholesterol, blood sugar, and hemoglobin, and we have this on the bedside. That's a family health team. When the community caregivers go into the community from house to house, they just give them the kit with point-of-care devices in a backpack with a solar panel that can charge the devices if required, and that's the dashboard that can be generated. So this proposal is to have So proposal is to have 1 kit per family health team that goes into the community. And that's the paramedic team. I'm sure you know what happens. They get a call, and then the ambulance drives 50 kilometers one way just to pick up the patient and come back. And once they come to the district hospital, they do an ECG just to realize that no cardiac changes. The patient has to be given a paracetamol and waits in the queue to go back by the patient transport vehicle. So what we're saying is, let us give them the devices so that they can, if there's a chest pain, then do an ECG at where they pick up, and then send it across using technology, get advice to say, yes, there are cardiac changes, bring the patient or leave the patient behind. The past decade has seen rapid development and the adoption of technologies that change the way we live. We look at the progress made in the industry in general. You can see touchscreens being used in food and retail. If you walk into Wimpy's, the waitress doesn't even write down anything, just goes and punches and tick, 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 you get the invoice. By the time you finish your coffee, your bill is ready to pay. And other day, I took my car to BMW for servicing, and they took my key and then put it in a docking station. And out comes a printout, and she says, doctor, you have driven this car on so-and-so day, and you didn't use the seat belt for about 40 kilometers. So it is possible in other industries, but we are a little bit behind. We don't have a PC designed for health. let's start. We're talking about robotics, but we don't have a PC that is designed for doctors and nurses to use it. The other challenge what we have is still struggling to get computers in the consulting rooms. If we get computers, the connectivity is not good enough. So we don't have the infrastructure to support us as well. As we speak, our healthcare practitioners are using the personal smart devices and to contact and get advice from their peers. Some of the technologies are on the horizon. Others are already in our pockets. We use our smartphones to get assistance. None are systematically deployed. That is where the e-health strategy and the normative standard frameworks come in for us to put something together and start using the information collected by our healthcare workers in a progressive way. Each could represent an opportunity to achieve better outcomes for more efficient care. E-health is a disruptor. It's a disruptive innovator that will only continue to grow by engaging care providers and patients to seek alternative ways to meet their healthcare needs in a cost-effective and a personalized way. I thank you. That's me. Thanks.